Hello, Dr. Fiona.
Hello, sir.
Hello, Dr. Fiona. Can you hear me?
Yeah, I can hear you.
I can't hear you.
Okay.
Yeah, now I can hear you.
Yeah. Okay. All right.
Was clear?
Yeah, voice is clear.
Okay. Good to see so many people have joined us. Fiona is a very popular teacher. So I'm just sharing the screen. Give me 1 second. Fiona, just check if it is recording.
It is recording, yes.
Recording to the cloud.
Yeah.
But
Should I make you the
when
host
my
or should I
computer is...
share the presentation?
Uh,
Okay.
so it will save to your computer, I think, the recording.
It says request to record to computer.
So
Or
you
record.
record on your computer
So
or
that is
cloud anyways, I mean.
participants. That is participants setting. I think this will automatically save, sir.
No, but are
It's
you
connecting
recording?
to server, so it's showing that it is getting recorded.
That instruction I'm giving, I'm just making sure that it is recording at your
I wouldn't know that unless I close the meeting. Can I do that? Your voice is breaking, so we are not able to hear you.
shut and join again. That's what you're
Yeah.
saying.
Yeah.
It will be flashing on your screen, the recording button, the
Yeah,
red
it
color
is.
button.
Yes, it is on the right hand, top right hand.
Fiona, hi.
Yeah, hi, sir.
It's recording now. It's recording now.
Yeah.
Wonderful. So I think we can start. Most of the people have joined. So before we join, we'll just like to introduce Dr. Fiona. Fiona, is my screen visible? Voice is clear?
Yes, yes.
So I welcome all of you to this a demo class. The Fertilis Academy is organizing a demo class on the why Euploid embryos fail to implant. The topic will be dealt with by Dr. Fiona Dsouza. She's the head of scientific operations at Anderson Diagnostics, Chennai. And I'll moderate the session. I'm Dr. Sarabpreet, and I'm the academic director for Fertilis Academy. And we'd also like to brief you before we start that there is another demo session coming up on recurrent pregnancy loss versus recurrent implantation failure. We'll be talking about the immunological aspects. Dr. Lipika is the speaker. She's a consultant at Bhubaneswar or Cuttack. And I'll begin. This is going to be on 20th July, and time is 20th August, and time is 5 p.m. onwards. And an upcoming course, I think this is the right time to brief you about the upcoming course on reproductive immunogenetics. The course starts on 25th of August, and it goes up to 5th of September. There are 4 sessions, and we will be covering immunology of RPL, RIF. We'll be talking about the basics of the immunology of pregnancy, and we'll be covering the lab aspects of RIF. How can we really do something in the lab which improves the RIF? Again, the last day ends with the Dr. Fiona taking up genetic insights of recurrent pregnancy loss, and Dr. Rajni will be talking on endometrial receptivity assay and its clinical applications. We'll also be talking about the most common diagnostic modalities, how to interpret them, and what are the novel ways of immunomodulation. So, a lot to offer in these 4 days of immunogenetics. So, I would definitely encourage you to join this course. And before we start, I would like to introduce our star speaker, Dr. Fiona D'Souza. She's a She's a PhD and she's heading the scientific operations in at Anderson Diagnostic Private Limited, Chennai. She's a PhD from Manipal Academy of Higher Education, and also a certified. She's in a certified program in genetic testing and sequence technologies from Harvard Medical School. She has over 15 years of experience in reproductive genetics, and she also heads the operations in Sri Lanka and Nepal besides India. and she has got over 13 publications in high-impact journals. She's an invited faculty at various national and international conferences and is a member of IFS Special Interest Group on Applied Genetics. Specialization is PGT, non-invasive embryo quality assessment, endometrial receptivity and rejuvenation. And she also has a keen interest in PGT and preventive genetics. She's an industry member for human genetics, SRM technology, SRM Institute of Science and Technology, and is also a guest faculty at prestigious universities of Colombo and Ruhana at Sula. So, a very little introduction for a very great speaker, Dr. Fiona, and I'm sure you're going to enjoy her session. And she's going to take you to the journey of why Euploid embryos failed. So, I'll just leave it here and ask Dr. Fiona to resume. Dr. Fiona, over to you, and I'm sure people are going to benefit a lot from this session.
Thank you so much, sir. Very good evening, everyone.
I think
Yeah.
you can start now. We have around 70 trainees with us.
Yeah.
So all the best.
Thank you, sir. I hope my screen is visible.
No, till now, yeah, now we can see the screen and yeah.
All right. So today we're going to discuss on why euploid embryos fail to implant. So this is a demo class for our upcoming reproductive genetics course. Reproductive genetics course is split into 5 modules where we take you through basics of reproductive genetics, the most common genetic disorders, how we diagnose them, how we handle prenatal genetic testing for these disorders, how we handle pre-implantation genetic testing for these disorders, and how we deal with the results. The course is information packed with very experienced geneticists who will help you understand how to read reports, how to interpret them clinically, how to do genetic counseling. So all this information is included in our course. So we just wanted to give a primer to this very interesting course to you all. So if you're interested, please do get in touch with us and register for the coming course. So assisted reproduction has been around for almost 4 decades, and we all know that the success of ART technologies is quite limited. Multiple factors limit this success rate, which includes mainly chromosome number changes, which are a challenge for both natural conceptions and ART conceptions are definitely no exceptions. We have to deal with anatomical defects, hormone disorders, risk of infections, sperm defects, endocrine disruptors, and also lifestyle choices have a significant impact on the outcome of IVF cycles. So it is a known fact that as a woman ages, the number of non-chromosome complement carrying embryos, what we call euploid embryos, is significantly going to reduce. And this is also shown in natural pregnancies where abnormal chromosome complements are not compatible with life. So if when we look at miscarriages that happen in natural pregnancies, 50 to 60% of these miscarriages are mainly chromosomal in nature. So when you come to IVF, you deal with not just miscarriages, we also deal with implantation. So one of the most common modalities used when there is a good quality embryo which has failed implantation, PGT comes into the picture. So pre-implantation genetic testing is basically a molecular diagnostic technique which is performed on a trophectoderm biopsy to give us a clear picture of all the chromosome complements of the biopsy, that means the embryo. We get to see all the chromosomes if they're in normal number or not, and based on that, embryos are selected for transfer. Now, PGT will divide your embryos into 3 main categories: euploid embryos, which have normal chromosome complement, which have a high likelihood of a successful pregnancy and have high transfer priority. Then you have the abnormal embryos, which are the aneuploid embryos. These represent embryos with chromosome number changes, and these embryos are usually lethal in the sense there is a very high risk of a miscarriage or an implantation failure, pregnancy loss, and because of that, they are not selected for transfer. There is a middle category of embryos called as mosaic. This is a mixture of normal and abnormal cells present in the same embryo, and therefore, if it is represented in the biopsy that comes to the genetics lab, we will be giving you a mixed result. So mosaic embryos have long been considered a gray zone of PGT, and their implantation potential is quite confusing to most people. And guidelines have been evolving to define and understand how mosaic cell works, why is it present, and how does it get resolved. So based on the most recent ESHRE guidelines, we can divide mosaicism as under 50 and above 50. So 50 was designed as a cutoff point. Below 50% mosaicism was considered as no mosaic, and above 50% mosaicism is considered as high mosaic. Now, when it comes to aneuploidy, embryos are quite different. There are many different types of aneuploidies we see. We see segmented aneuploidies, full chromosome aneuploidies, and these all can impact the ability of the embryo to implant survive, especially when it comes in the mosaic category. So mosaic is a kind of subcategory of aneuploid embryos because they're not fully abnormal. Part of the embryo can be euploid. As you can see in this representative image, the biopsy can show that it is a mixture of euploid and aneuploid cells, because the blue represents the normal cells and the orange represents the abnormal cells. But it is entirely possible that the inner cell mass is conserved and the embryo has implantation potential. So just to give you a fair idea, we had a fantastic paper by VOT et al. Way back in 2021. They evaluated the outcome of about 1,000 embryos, which were mosaic embryo transfers. What was very interesting in the study is you can see the first bar is euploid embryo. So image A is the implantation potential, image B is the ongoing pregnancy rate or live birth. So if you look at the data, in euploid embryos, they are able to achieve 57% implantation and 52% ongoing pregnancy rate or live birth rate. So what happens to the remaining about 43% of the embryos? They are going to fail implantation. So it is generally an assumption that PGTA is going to guarantee a pregnancy. No, that is not the case. PGTA is going to reduce the time to pregnancy, significantly reduce miscarriage risks. But it does not mean that your pregnancy is guaranteed based on the euploid embryo transfer. So this is one of the most important things I wanted to highlight with the use of the study. Secondly, then they prioritize embryos based on the type of aneuploidies, which is segmental. In mosaicism also you have segmental mosaics and you have whole chromosome mosaics. So low segmental mosaics priority, high segmental mosaics priority 2, because segmental aneuploidies are not always uniform. Then you have low mosaic in one chromosome, low mosaic in two chromosomes, then complex mosaic. This is more than 3 chromosomes are showing mosaics. So we can see that the implantation potential gradually decreases in this category, and this can still sustain up to 40% live birth rate in this category. Therefore, we should be transferring mosaic embryos with precautions, with proper counseling. They can give live birth, therefore should not be discarded. So when we move from complex mosaic, from low mosaic, 2 chromosomes to complex mosaic, there's a significant reduction in the prognosis, right, of the pregnancy. So does the case when you have high chromosome mosaics. So when you have high mosaics, the possibility of miscarriage, implantation failure or miscarriage increases to about 70%, and therefore they have the least preference of the preference. So when you look at RIF, we still in RIF category when PGTA has been employed. So advanced maternal age and RIF are the 2 main indications for PGTA as well. RPL is next with certain caveats. But when you look at actually, when you use PGTA embryos in RIF cases, it has been reported that they do face a 30% failure, okay, in the RIF category. This is a clinical reality. So definitely it is well evidenced and documented that euploid embryos are able to fail implantation process, no guarantees. In about 10% of the cases, these are idiopathic, but another 20% we have some solutions to it. I'll come to it as we go forward. So we still have requirement of at least more than 3 euploid embryos to sustain a pregnancy in the RF category or any IVF patients for that matter. These are dependent upon multiple factors. Okay, so this first, the euploid is ruled out by PGTA, but the quality of the embryo matters quite a lot. So embryonic factors are the most important thing. And let's look at PGTA per se. PGTA is not a cover-all list. PGTA has limitations. PGTA cannot really determine the nature of the inner cell mass. That is a technical limitation. The current PGTA that you use everyone thinks it rules out all the chromosomal conditions. That's not true. The current PGTA that we all use cannot rule out triploidy or haploidy. It will technically report these two categories as euploid because it's a technical limitation of the platform that is used, which is the MGS platform based on a copy number variation testing. Secondly, DNA fragmentation is an important factor here. Now, what happens with DNA fragmentation? Most cases, DNA fragmentation is paternally inherited. This DNA fragmentation cannot be repaired by the embryo. Embryo has limited repair mechanisms. And as the embryo is growing so fast, the mitotic errors accumulate and apoptosis is not happening. Now, in a healthy individual or maybe post-implantation embryos, if there is DNA strand breaks, you have repair mechanisms in place and the cell is designated for apoptosis. And then there is cell death and that cell is digested. That is not the case in embryos. In embryos, apoptosis is not active, therefore it is conserved. You are having an accumulation of DNA fragmentation at cleavage stages, which manifests only at the blastocyst stage, and apoptosis is not visible to the naked eye. Apoptosis cannot be detected by PGTA. There is a possibility that in the biopsy are apoptotic and it shows a chaotic result. That is something else entirely. But here and there, when the cells are apoptotic, it is DNA fragmentation. It can significantly hamper A, blastocyst development. First thing, it is a well-established fact. B, you will have implantation failure and you can face biochemical pregnancy loss and early pregnancy loss. And this has been well established. Okay. Then is epigenetics. Now, there are imprinting genes that control the entire process of implantation as well, because this is a multifactorial process. And right now, there are no investigations done, and the current PGTA does not include epigenetic modification. So this is an area of research going on. There's some good work going on in this particular segment. So these are embryonic factors. Then, of course, it is the so this was the paper that I was discussing about. Have this methylation impact. There was a study conducted by this Chinese group that looked at the global methylation pattern in embryos undergoing transfer. And what they found was they found a very limited window of a cutoff between 0.21 to 0.31. So this is basically a range of the level of methylation found in embryos. So as the methylation reduces, in the sense if the embryo is hypomethylated, or the methylation increases, in case the embryo is hypermethylated, there is a change in the pregnancy outcome. So in this particular range, from 0.21 to 0.31, you have the best pregnancy rates, you have the lowest miscarriage rates, and you have the best live birth rates. So as and when we move away from this range, the pregnancy outcome significantly drops. So this was a very interesting study. Then, next is the endometrium, because of course we know implantation is an interaction between the embryo and the endometrium. There are two main factors. So in the endometrium, its receptivity significantly impacts implantation. Of course, if there is a shift in the window, and it is understood that almost 30 to 40% patients who undergo IVF have a shift in their window of receptivity. Now, this is a highly debated topic. The large-scale studies do not find any difference. But what we observe is in the subset of patients who actually experience this shift, there is a significant impact of endometrial receptivity, and the next cycle helps us achieve a pregnancy provided the embryo is euploid. So euploid embryo in the right window of implantation is going to deliver you pregnancy. And next are endometrial pathologies. Obviously, if the endometrium is not in a great quality, we are not going to be able to achieve implantation. And one of the most commonest causes are chronic endometritis and also the uterine progesterone resistance. This can be triggered by subclinical endometriosis or some other pathological phenomenon. So to look at the chronic endometritis, we can look at the chronic endometritis panels that is basically working on an endometrial biopsy. It evaluates a series of organisms which can cause infections. So infectious chronic endometritis based on the organism can be treated. You also have endometrial dysbiosis. So the microbiota in the endometrium has to be balanced with the dominant lactobacillus. So if the lactobacillus, if it's not a lactobacillus dominant endometrium, and there are more pathogenic bacteria there, it can again disrupt the microbiome balance and then go and cause implantation failure. Immunological factors are the next important factor. It is a really upcoming stream, and there are a lot of good information coming out, a lot of good studies on the impact of immunological factors. So the endometrial immune system is quite unique from the rest of the body. It is designed to recognize the embryo and protect it. If this mechanism fails, there are a possibility of the uterine natural killer cells attacking the embryo instead of protecting them. You also have the cytokine imbalance, which can impact the endometrium. So it can become toxic to the embryo and fail implantation, or even if the embryo implants, face biochemical pregnancy loss in such cases. So it is important to identify what is the practical composition of the endometrium. Is the microbiome balanced? Is there any pathogenic bacteria? Do a protocol accordingly. This coupled with the Euploid embryo will definitely be able to restore a better implantation potential. And you also have the probiotics that are available. So NK cell activity can also be evaluated in the same endometrial sample. So there are two ways of looking at NK cells, the peripheral blood NK cells and the endometrium. So when you compare these two as a diagnostic platform, the endometrial NK cells are more informative than the peripheral blood NK cells, because that is the environment where the embryo is going to be implanted. And an altered cytokine profile, we call it Th1, Th2 balance, and this change can also impact it. So the detailed process and way it impacts the implantation potential, we will discuss in our immunogenetics course, basically, which helps you understand what are the inflammatory cytokines, what are pro-inflammatory cytokines, what if it is imbalanced, and how do you treat it, how do you improve that, how detect it also. There is a series of investigations that we'll be discussing in that. So the implantation roadmap basically includes a comprehensive patient assessment. First, we need to look at have you transferred good quality embryos, right? If the embryos are not good quality, then you really can't be blaming its blood status. And morphology does not correlate with embryonic euploid. You can have a BC grade embryo, which is euploid, and you can have a AA grade embryo, which is aneuploid. So morphology does not correlate with PGT results, but morphology definitely correlates with implantation ability. So there will be a differential implantation ability between the quality of embryos. And definitely we need to employ proper screening tools and risk identification to see what category the patient is falling into. Instead of giving blanket treatment therapies, should be looking at endometrial receptivity, chronic endometritis, the microbiome, immune profiling, as well as the treatment should be planned accordingly. So based on the finding alone, the treatment should be done. So if there is no need for a particular therapy, it can further compromise the outcome. So therefore, diagnostic testing is done, then a personalized treatment is done, and then you monitor how the outcome is working for your center. And once you know it is working, you can implement it in a larger scale. Why? Because the information on immunological profiling is evolving right now. And endometrial receptivity also. There are two schools of thought when it comes to receptivity and immunoprofiling. There is a section of people, scientists, who believe this is going to make an impact, and there's a section of people that don't. Individual experience, the clinic data will help you understand, is it really working for you? Is it something sensible enough to offer to patients? Because these interventions are not economical. They are going to be expensive. So what is the most strongest evidence is definitely a CD138 immunohistochemistry can be diagnostic of chronic endometritis. And you can also employ an alternate marker called MUM1. BCL6 is a very nice indicator for progesterone resistance in the endometrium, can be used for. Microbiome analysis and receptivity can be evaluated in case a Euploid embryo has failed. So this will help us further optimize the outcome of the cycle. So to vaguely summarize, you have embryonic factors which include gene function, the metabolism, because the mitochondrial turnover also impacts implantation. You have DNA fragmentation. You have the transcriptomic profile of the embryo, which we have not evaluated yet. So it is still an upcoming investigation. And now we just know the implantation window of the endometrium. We don't know how is the transcriptome of the embryo, how the mRNAs of the embryo interact with the endometrium. That is still evolving. The synchronization between endometrium and embryo is also very important. So ideally, it is understood that if it's a day 5 or a day 6 embryo, it should be transferred to a day 5 endometrium. If this transfer is not synchronized, then we may face an implantation failure. Receptivity alone is not sufficient. We have to look at other uterine anomalies and endometrial pathologies. So these are the main overview why the euploid embryos fail for transfer. I would also like to grab my attention to this really beautiful paper from Human Reproduction. This was a large-scale review, basically, that looks at why euploid blastocysts fail to implant, and they evaluated so many scenarios, and it will give you a clear picture that it is not just we who are facing implantation failure in euploid embryos. So many multiple factors affect it, all the factors that I mentioned now, and there is evidence to support it. So a structured investigation-based approach can identify why an euploid embryo transfer has failed. So what we should not forget is the most important criteria is the quality and euploidy, but extra-embryotic factors also play a crucial role. So we are doing a lot of research on this front and developing the information and data to publish to understand how immunological factors affect embryonic implantation. Thank you. So this was just a briefing of what we will be discussing during our course. If you have any questions, we are open to address it. Any questions, you can just unmute yourself and you can ask us, or you can add it in the comment section. What is the identity of chronic? I think it is chronic endometritis, if I'm understanding correctly. So I'm not the best person to comment on treatment modalities because I'm not a clinician. I work on the diagnostic side and I'm a geneticist. So basically what I can tell you is you need to investigate what is causing the infection, what organism is causing it, and then you can do an appropriate antibiotic therapy. Yeah, HLA typing. So HLA typing is a very interesting phenomena. It is an upcoming investigation, and basically the concept is the embryo should be immunologically different from the maternal side, right? From the maternal endometrium. HLA is basically the major histopathology complex, which helps the immune system understand the difference between a cell that belongs to us and a cell that is coming from outside. So the embryo is a mixture of both maternal and paternal DNA. So it has different HLA marks. It's a heterogeneous HLA mark. If the male partner and the female partner have more common shared HLA alleles, they are more identical. So the embryo cannot be fully distinguished by the immune system, and that way the immune system can reject it. So this is mainly HLA. Then you have a factor called HLA-C. So these are basically receptors on the embryo, and these interact with key receptors on the endometrium. So there's an interaction between the two, and based on the type of key and HLA-C interaction, the immune system will function. These are investigations you can run for the couple, and based on that, you can get an idea and treat the patient accordingly. You have immunomodulators based on the findings. What kind of test must be done to identify NK cells? So NK cells can be identified with endometrial biopsy. An immunohistochemistry test for CD56 can be performed to identify NK cells. Can immunomodulation treat hyperreactivity of endometrium? Yes, it can. Immunomodulation can slightly suppress the endometrial immune system to make it more conducive to sustain the pregnancy. So when it is immunogenetics challenge for the embryo to implant, what we need to keep in mind is it's not just implantation it's going to affect. It's also possible that implantation happens but not completely. If you can have biochemical pregnancy loss, you can also face preeclampsia, because what it does is it causes resistance to the proliferation of the placental tissue. This can also cause preeclampsia at a later stage. So this is something also you need to handle. So when you have immunomodulation, you also have to put the patient on. Apparently, it's been reported to health. Okay, there is a question on father of the person has recessive disorder. First child has dominant disorder. If the patient goes for second child, what are the chances? So this is basically apart from euploidy. Now, if the male partner has a dominant condition, dominant disorder, then 50% chances of it coming to the baby. If the male partner and the female partner both are carriers of a recessive condition, there's a 25% chance of the child getting affected. In this particular case, you're telling me that the father of the male partner is having a recessive disorder. So the male partner is not affected, So he'll be a carrier possibly, or maybe not a carrier also. You need to run a test between the intending couple, a carrier screening test, to identify the risk factors, because if they are married within the family or in the same community, they can share common diseases, and because of which they can be risk to the child being affected. So based on that, you can do that. What is the best test to be done for recurrent implantation failure or miscarriage? So the best test to be done for recurrent implantation failure cannot be a single test. But for miscarriage, yes, there is a cascade of tests to be done. For pregnancy loss, the first test to do is karyotyping. Once the karyotyping has been established or a product of conception testing, based on that, you can take it forward. There's a series of investigations that can be planned. For recurrent implantation failure, as I said in my presentation, you can look at the embryonic factors, but you can't look at all of the embryonic factors. These are for experimental purposes only. So embryonic factor of PGTA can be done. Endometrial factor, you can evaluate all the challenges that we just discussed: the receptivity, the microbiome, the immunological testing, especially the endometrial panels. Is there any significance of microscore? Yes, there is a significance of microscore in embryos. You tend to have the best implantation potential with the lowest microscore, but it cannot really explain implantation failure, and it cannot really define that this embryo can or cannot implant. So microscope gives us an idea of the activity of the embryo. So if the microscope is high, that means there is a lot of activity happening. This is not an ideal state. Ideally, embryo should be metabolically quiet. Microscope should be on the lower side. However, because of certain research limitations on embryos, there's no proper cutoff that is defined for microscope. You have varying studies saying that, say, around 20% is okay and more than that is not, but you can't really define that, because as biopsies are done at different stages. So a genetics lab does not always get the image of the embryo, right? And biopsy grading is subjective. So a smaller embryo, an earlier blastocyst, will have larger trophectoderm cells. So the cell mitochondrial to nuclear ratio is changing. Compared to a fully expanded blastocyst where you have smaller trophectoderm cells, again your mitochondrial nuclear ratio is changing, which is nothing but microscope. So because of this change, depending on the size of the trophectoderm cells and the size of the biopsy, the microscope is going to be changing. So that's a confounding factor, because of which it is difficult to develop a cutoff. So if you have more than 2 euploid embryos available, when you want to choose between, we chose the lower microscope so that it has a better implantation potential. Okay, I think we've addressed all the questions. Great. Yeah, so HLA test is basically a blood test. So the question posted is a briefing about HLA test. It's a blood test, and you can basically look at HLA A, B, C, and you look at certain points of the HLA, and you can evaluate what is the matching. So this is not an individual test; it's a couple test. You need to do it for the husband and the wife, and you need to see how many alleles are matching. So higher the matching alleles, higher is the risk for the rejection of the embryo. So ideally, less than 2 is fine. More than 2 alleles matching, there is a possibility of the risk. So we should understand that HLA is heterogeneous. You cannot always have this same problem with every different type. So when you look at the category of patients undergoing RPLRF, and then you look at shared HLA alleles and there's more common, then it is diagnostic. So it's a correlation between patient history and the findings. And then you have to look at also HLA C1 and C2 genotyping. So these things basically help you correlate it. All right. So if there aren't any more questions, we will wind up the session. So you are already in the group for this meeting. You can just text us on the group on when the course is going to start. And if you're interested, you will get all the details in the group when our courses are going to start. You can register for them. So these are basically 9 courses. We take you through the theory and then how we interpret the reports and how we handle the clinical management for each of the genetic conditions that we discussed. So the immunogenetics course is a complete separate immunogenetics course. You have other clinicians on board who are well experienced in handling immunogenetic compatibility issues. And then we have our genetics course for all the simplified version. So these are application-based courses. We are looking at how is this information is going to be clinically relevant. So it's more of a practical based approach on actual case scenarios, and then we can take it forward. Okay. So thank you so much for your kind attendance, and be in touch with us, and you can attend our class for any further details. Okay, so I will be closing the meeting now. Thank you.